So without ado, we shall go on to our first speaker. Our first speaker is Dr. SAURABH LUTHRA, who's the director at the LUTHRA Vision Eye Care Center at Bilaspur, a very skilled, prolific surgeon abreast with the latest in the field of cataract surgery, and he's going to show us a challenging case. On to you, Dr. SAURABH.
Thank you for kind words, ma'am. So I think my video is seen. Can I have a thumbs up on that, Harshul sir?
Yeah, Saurabh, please go ahead. Yeah.
Yeah. Okay.
Yeah, please.
Yeah, sir.
You need to be a little louder, SAURABH.
Yes, ma'am. So I'll be presenting a case of Phacomorphic glaucoma. As you can see, it has a very shallow AC, a 1.89 AC depth. So I'm starting with a very careful side port incision so that I should not puncture the capsule. Blue dye is injected to stain the capsule. I push a little visco so that I have some space to enter with my main port incision, a very precise incision. A very careful small nick is been made there so that we don't expect a sudden gush, because this is a case of phacomorphic, and the we have a very liquefied elastic kind of a cortex there. So I'm trying to aspirate some liquefied cortex with the first with the hydro cannula. It doesn't work. Now I go with the visco cannula. You can see those cheesy material coming into the cannula so that I reduce the intralenticular pressure. Yeah, so on the high mag, it is even much more clearer. So I go with my cystitome here because I am very much comfortable doing my rexis with the 26 gauge needle. But somehow that day is not my day because it's a very fragile capsule, and I'm again taking off as much liquefied elastic kind of a cortex by my cannula. So now I decide to open the incision completely with the 2.8 so that I can enter with my Haldipurkar micro rexis forceps. So I again, try and get back to my rexis so that I have a fairly all right rexis. I again go back with my cystitome. The whole key is to be very patient, but it doesn't work. So I have to put a small nick because I don't want to lose my rexis there. So after this small nick has been made, again I try with my cystitome, but somehow it just doesn't work because it's so fragile, and I am scared of losing it. So again, this comes to my rescue. And yes, as the music changes, my heartbeat also changes, that yes, now we are back on track, it is going well so far. I come back now again, somewhere here it is again kind of stuck, it doesn't want to go. So probably my direction is wrong, my heart is beating faster here, but yes, again, patience is the key. So I change my direction, go down, and then finish it off there. See, you can see how elastic that was. It was so difficult to manage that, but yes, God was nice, my day was all right. And I first go inside with my IA probe to take off as much cortex as I can, again to make space for my surgical phaco probe to go in comfortably. And this will make my capsule also my nucleus also mobile. Again, here you have to be very careful because the nucleus is soft, not very hard. I'm a stop and chop guy. I'm very much comfortable here. But again, it doesn't move very comfortably. It takes its own sweet time. So after breaking it, I very gently try and engage the nucleus,
1
bring it
minute
out,
left.
give a small, chop it. And yes, so that's, again, the game is again back on me. So I feel that now I can go ahead easily, but that's where the patient, kind of moves. So I try to bring it out a little so that, things go much more comfortably and smoothly. So the battle was half won here, and after a nice IA wash, there goes my lens. And I think I've done what I could have done in those available settings with my mindset and the patient scenario. So thank you so much for this opportunity, and I've just cleared the angle so that I don't have any more, viscoelastic stuff there, and nicely hydrated the wound there. Thank you.
Uh, that was a lovely video, Dr. SAURABH.
Yes, ma'am.
Yeah, it is probably, as Harshul would also agree with me, maybe this gymnastics would have not been so challenging if you had made a smaller axis to start off with and then enlarged it.
Yes, ma'am, I have somehow tried that, but somehow in my hands, this works much more comfortably. Like after I've made that mistake at times, I've not been able to enlarge it so well. So that's how these gymnastics come in between. Keep taking as much the cortex as I can, with very gentle or rather no pressure onto the anterior so that it doesn't go off. Because in this COVID times, everybody will agree that we've been operating every third case as a mad cat, at least in my part of country. So this somehow, not the making the whole small pieces first. This how works well in my hands. So I've been, trying to do this.
And also pulling the rexis towards the center. That would also keep redirecting it,
Yes,
especially in these elastic capsules.
yes, ma'am.
Dr. Suhas, you are there?
Yeah.
Yeah, I just wanted to know, like, it is possible in these kind of intramuscular cataract to have a rexis extension. Do you actually believe that you had a extension at one point? You would like to make a neck on the opposite side so that there's a better redistribution of forces. Do you believe that concept?
Well, of course, I do. Well, of course, I do. In fact, Saurabh was very lucky and he really managed it well. Can you hear me?
Yes,
Yes.
sir.
There
Yeah.
is some audio disturbance. Sunil, you need to check. It's coming
Yeah,
in
there is.
everybody's audio.
What?
It is coming in everybody's audio. There is some disturbance somewhere. When Saurabh was speaking, it was coming. Now Sir is speaking at that time also, it's coming.
Now it's fine. Yeah.
Now it's okay. Yes, sir.
Yeah. In fact, Saurabh, you really did a good job. It was a difficult one to really get out of it. But then you did say that when you made a puncture and wanted to aspirate, nothing much was coming. So that is probably the time when you would fill in viscoelastic again and make a rexis. But like how Chitra said, if the rexis tends to go on one side, it's better that you stop there, put some dispersive viscoelastic and go to the opposite end and make a cut. So it kind of balances it. And then you have time to, complete it. But of course, it was difficult to access and you did it and somehow managed to get it complete. I think it was a well done job, but the start probably could have been made a little easier by making a smaller axis. That's what I guess.
I have one other question. In these, a combination of a very small eye, a phacomorphic glaucoma, what is the role of a limited past plana vitrectomy being done in these eyes?
I think, Chitra, you have to be very, I mean, I know that glaucoma surgeons, I know Dr. Tanuj does this limited anterior vitrectomy for such cases, but I think it probably has a role, but I think the way Saurabh showed, you can get away with it even without doing a limited anterior vitrectomy, unless the AC is extremely, extremely shallow. Here it was not that shallow, so he got away with it. And I think these cases are very tough and difficult and very well managed case, Saurabh.
Thank you so much.
And one word about Suhas Haldipurkar forceps. It's really, really a great tool and a must for everybody to have it in their, tables. It's really useful.
In our unit, yes, ma'am. True. I am a very comfortable Zepto surgeon, ma'am, but this one did not give me the space at least, to think about doing a Zepto there because I have it and I've been really doing it for quite some time. But the AC was so shallow that there was hardly any space for the probe to go in and to be placed and then, to play all those gimmicks. So this had to be handled. God was really nice that day to me, ma'am.
Very well managed, Saurabh. I mean, I just have a comment to make that this is one situation where a femto laser really makes a difference. We all know about the cost factor, but this is a truly an indication for using an LRCS. And you, of course, did a Rexis, managed it quite well. But I would, in these situations, more doing an anterior vitrectomy, preoperatively giving glycerol, and even though I may not give a peribulbar block, I make sure my sisters give a considerable amount of massage, about 5 minutes. I do believe that softens up the entire eye and makes the surgery more controlled. And I go through the side port for creating even if I'm needing a needle. And in case I have to extend it further, I would use a microrexis forceps through the side port. I think that prevents the shallowing of the anterior chamber a little more. And when it tended to run off on one side when you are going, I would go ahead and do this brand little maneuver. That's a little difficult to explain by words. But you flip the capsule back and pull it in the direction in which you're tearing and towards the center. That more often helps you to bring it back into the center. I think otherwise you did very well. But I would always go through the side port.
Thank you, sir. I was trying to
Ma'am,
do that, sir. I was really wanted to do that, but I was so scared of this elastic capsule that I was not sure that if that maneuver in this particular capsule, the kind of fragile it was, it would work.
Actually, it's a little difficult to comprehend, and you don't feel very confident initially. But
Yes.
once you have done it a couple of times, don't go for an extreme situation like this. But even in an earlier situation, if you think instead of it going in a curvilinear fashion, it's going a little straight, then immediately try to do that. You do a few times, you feel very confident with it. And it's the idea is not only pull it towards, but also towards the apex of the cornea.
True.
Then you find that it gives you much more control.
Yes, sir.
ma'am, I had a patient, a similar patient, where we could not even give mannitol pre-op. So we just did a pars plana port, and we didn't do actually an anterior vitrectomy, but just vitrectomy at the tip, at the edge. And that itself helped to reduce the intraocular pressure, and the chamber could be deepened well. So maybe that is one more thing we can do. Because it's a blind procedure, and you cannot actually do a vitrectomy without, there could be a damage to internal structures. So this was something else.
So can I add a quick comment, sir?
Yeah. Totally.
Yes. The basics, what we generally have to follow is keep the flap flat. Each and every time, inject OVD, make the flap flat, catch the flap at the very near to the tip of the rhexis margin and not away from it, and try to make smaller sized rhexis in such cases. But I don't know if pars plana vitrectomy will help, because it is raising intralenticular pressure than IOP. Of course, IOP is raised. This Phacomorphic glaucoma, but
I mentioned it's a very small eye. That's all.
Yes.
That's all.
So this may help. Thank you.
Harshul, you have anything to add?
No, I think SAURABH managed it very well. Only thing is that in intumescent or pediatric cataract, when we are doing capsulorhexis, I think the microcapsulorhexis forceps, as Dr. Ramamurthy also said, it's very helpful. I don't think that we should try to do with cystitome, because the radialization chances are very high in these cases. So always try to do with the capsulorhexis forceps, so that you can change the direction whenever you need. You can use all the different kind of maneuvers. Very well managed, Dr. SAURABH.